electronic beat. Okay, good morning and welcome to the meeting of the Senate Finance and Appropriations Subcommittee for Health and Human Resources. This morning, the subcommittee will continue with budget briefings on the proposed budget, and today we will learn more about the budget for the Department of Behavioral Health and Developmental Services from Commissioner Nelson Smith. Staff will also provide an overview of the proposed budget for all of Health and Human Resources. But before we get to those presentations, we have 4 bills to consider this morning. And the first one on my list is, well, we've got Senator Head, who's not on the subcommittee. And Senator Head has 155, right?
Yes, sir.
Okay.
Thank you, Mr. Chairman. We have Senate Bill 155. This bill is addressing the Healthcare Workforce Development Authority and is seeking to pull everything into a little bit better posture and give the authority some better opportunities to work more streamlined. We do have, I'm got to see if I can find I thought my notes were right on top here, so I apologize. We have created, as you're walking through this, several things that changed from the initial bill and the substitute that was adopted in the Education and Health Committee. One was the creation of the Healthcare Career and Technical Training and Education Fund. There is a budget amendment for that. We had neglected to put that into code, the creation of that, because we earlier in this bill directed the authority to be able to administer those funds, but there was no fund that yet existed. It will be created if it's in the budget. It would be created along with that. But we felt like, since hopefully this would be moving forward before we got to voting on a budget, that we might want to create the thing that we were telling them to direct it to before we got to that point. So that was added in and was there. But the main thing is this just streamlines the process and really helps us move things along for workforce development in the healthcare space. This has come to us from a lot of work that was done by a group from the Claude Moore Foundation, trying to create a healthcare workforce authority that would give people multiple on-ramps and off-ramps with their careers as they go through. And we've gotten a tremendous amount of support and a lot of work from this, and so really hope we can have a favorable outcome with this as we move forward.
Yeah, it's my understanding that you've submitted amendment and other people have submitted amendments to. There's a total of about $5 million of proposed spending attached to this.
Yes, sir. I think there's some duplication in that, I would imagine, but we all, a bunch of us want to make sure that this gets done, please. So
yeah. So what's your pleasure? Are there a couple of? Oh, okay, please, Mike.
Mr. Chairman, just and for the Senator Head as well, there's just a couple of things in looking over the bill that I might suggest is on, if you're looking at the bill, line 39, where it talks about evaluating primary care graduate medical education programs. The Medicaid program does more than just primary care, so I would suggest just striking primary care, because I know that the authority actually kind of deals with the entire Medicaid residency program.
I don't have any objection to that. I don't know if there's any of the folks I don't, nor do I think anybody else does. So,
all in favor of that amendment, say aye. Aye. Okay.
And then, Mr. Chairman, the other suggestion is on lines 53 and 54, paragraph C. It has this policy statement that the Commonwealth shall make an effort to match funding from the U.S. Health and Resources and Services Administration for their grants. I understand the reason for it, but we would not, I don't think, typically include such a policy statement in the code, because we would typically do that through the budget process.
And again, that is an aspirational statement, Mr. Chair, and I
The
would.
amendment would be to strike 53 and 54.
Or just change the word to the name.
So,
Well,
Does that make a difference at all?
Mark, is that,
Cut it out?
it's an aspirational statement, so I think we're okay with that. So,
Mr. Chairman, move to strike lines 53.
is there a second?
I just did.
Okay. Motion and a second on that amendment. All in favor, say aye.
Aye.
Okay.
And then, Mr. Chairman, just the last thing is, if you look on page 2, where it adds at the top in lines 69 through 70, it adds 4 ex officio members. 2 of them are the money committee chairs. Money committee chairs get appointed to a lot of items. So I'm just conveying on behalf of Senator Lucas that, just so that y'all know that.
Well, why don't we say that the chair or the designee of the chair?
Well, it kind of already says the designee, but
Or their designees.
I'm really just bringing it to your attention. If you want to leave it in, that's your
Oh, it
prerogative.
says that, okay. But the chair can appoint somebody else.
And Mr. Chair, I think it does on line 70, it says, and the chairman of the Senate Committee on Finance Appropriation or their designees. So I think we've already got that covered there, if that's okay, so.
Sure.
Okay, the
Okay.
bill was fully heard in education and health. Is that correct?
Yes, sir.
We're just here about the fiscal policy. So as amended, what's your pleasure on the bill?
Mr. Chair, I move that we report.
Second.
Motion made and seconded that the bill be recommended for reporting to the full committee. Do we have to record this vote or? Okay. All set. Anybody in favor, say aye. Aye. Opposed, nay. Okay. The bill will be recommended for reporting.
Okay. Thank you, Mr. Chairman.
Okay, do we have other non-members? Delegate Rome has got a couple of bills. She's not here yet. Senator Rome, rather. Senator Favola's got a bill, Senate Bill 43.
Program serving those with disabilities. And the bill locates this person in the Disability Law Center. The Disability Law Center, as you know, is a nonprofit entity, and it's statutorily designated as our watchdog agency over programs serving those with disabilities. To implement this function, the Disability Law Center asked me to put in a budget amendment, and I did. And I guess you can see it was $195,000, I guess, for each year that I requested dollars. And I think it's very much needed. The Disability Law Center understands disability law, understands the programs and services people must access. I think it's needed. And I just want to note that the Disability Law Center doesn't get state money. They get federal dollars, and they have to implement the federal civil rights laws related to access and other issues for those with disabilities. So to do this, they felt they needed additional funding.
Mike, do you have comments on this one?
I'm sorry, Mike. Yes, I did say that. Yeah, we don't have to use the word ombudsman. For lack of a better word, the person's not going to have investigative authority or the full range of authority, say, like the children's ombudsman has in the administration. This is really somebody who can sort of run interference when an individual can't get an answer from the administration or can't find the appropriate program to serve their needs.
So would the suggestion be to take out the word ombudsman?
Yes.
Say a program instead of an ombudsman
Coordinate.
program, and then take
Program.
out the word ombudsman otherwise? Okay.
Yeah, that would be my
Senator
suggestion.
Obenshain.
So my understanding, and this is a new area to me, the Disability Law Center is not a state agency and receives no state funding. So we would now be funding a position within the Disability Law Center?
Yes, yes.
But there's nothing about this language.
Would you
required.
like Mike to answer that?
Yeah, Mr. Chairman, and Senator Obenshain, to your question. So yeah, the Disability Law Center is a nonprofit. By federal law, every state has to have a protection and advocacy organization for people with disabilities. And so it used to be a state agency prior to 2014, but they made it a separate agency so it'd be more independent of the state for its advocacy role. And so really what it would become is like a pass-through payment to them if you did this to support this function.
So, Mr. Chairman, I mean, is this a departure from the path that we took in 2014?
Well, as I did research a few years ago, I don't know if it was 2014 or 2015, there was actually legislation passed that would direct the Disability Law Center to serve as an ombudsman for many areas that were state-run in our disability program. That never got funded. So at this point, there is no state money going to the Disability Law Center, and
Mr. Chairman? So do they not have resources from the federal funds that they received to perform this function?
I asked that question, and the answer I received was they can't, by law, the dollars they get through the federal appropriation process are earmarked and must be used for the specific federal purpose. That's the answer I received from.
So I apologize, Mr. Chairman. So how does the federal purpose deviate from the purpose of your bill?
The purpose of my bill is focused solely on state-operated programs that somehow are not necessarily serving individuals the way they should be serving them. So if an individual is trying to access a state program and can't figure out how to do it, can't get an answer from a program manager, doesn't understand which agency in the state could help them, that's where my bill would come in. My bill is only focused on helping individuals access state programs,
And the federal grant prohibits that?
I was told it did prohibit it. I am happy to ask Mr. Tweedy if he has additional information. I can only tell you what I learned through my investigative efforts to prepare the bill.
Mr. Chairman, and to Senator Obenshain's question, I don't necessarily know if the federal law limits it. I think probably the bigger issue is that the federal grant funding that Disability Law Center receives is limited. It doesn't, they're not going to increase their funding because they have an expanded function. So really it becomes like it's like a state mandate to do this, so the state would need to step up and fund it.
Senator Evan has some input.
I was just going to, I noticed that it is required by federal law, but I was just going to ask Senator Favola, is this basically a hotline or a service that if you have a disabled individual in your household, that you can have a resource to get information, not just information, but help in signing up or enlisting the services that you are already eligible for?
Yeah, it's not so much a hotline. It's intended. These would be individuals who can't seem to get an answer from the administration.
To advocate on,
So
to advocate for them if need be.
Right, to advocate and to cut through the red tape.
Thank you, Mr. Chair.
Okay. The bill is before the subcommittee.
I would move a motion.
Yes,
I would move to report.
got a motion.
As amended?
To report as amended.
With
that
the second.
Got a motion and a second to report as amended. All in favor, say aye.
Aye.
Opposed, no. One abstention. One contrarian up here.
Contrary. From Switzerland.
We will find a better name
Senator Rome's
than
got two
ombudsman.
bills. I understand we're going to have amendments before we get the full committee on that bill.
Yes, sir.
All right. Good morning, Mr. Chairman, to the members of the subcommittee here. So the first one we'll do is SB 320. So this is the WIC information for food banks. So regarding the money part on this, number one, the administration supports the bill. Number two, we understand that they could simply engage in a private-public partnership if they wanted. We don't think that there's going to really necessarily be a long-term hit here. And I think we've got someone who might be able to speak to that. But otherwise, my understanding is that there's not a significant fiscal impact on this. And so basically it says, like the impact says that it would be $173,756 for the position within the Department of Health as an expenditure impact. And I am in the process of continuing further communication with the department regarding the bill in order to discuss the fiscal impact statement.
And you didn't submit a budget amendment for this?
No, no, Mr. Chairman, the reason we didn't submit the budget amendment was at the time when we were filing the bill, we didn't have any fiscal impact that came in. This came in well afterward and after the deadline for that. And so we believe everything can just simply be worked out administratively.
Okay. Mike, have you, what,
Mr. Chairman, so, yeah, I mean, I think it really depends on the scope of what they do would really define the fiscal impact. I mean, if you're really just providing information and, about the pathways to access the WIC program.
Yes.
I mean, granted, it's not uncommon for the health department to want more resources to do these things. The one suggestion I have is part of the budget process. I mean, this would require them to work with the Federation of Food Banks, and I think in working with them, who already provide some of this information, they might be able to do this in a cheaper way. And we support the state supports the Federation of Food Banks with TANF funds. So we could probably work out something to make it, to help mitigate any fiscal impact on VDH.
you indicated that the administration supports this bill,
That's correct.
and you've had conversations with the Department of Health about taking on this responsibility.
Yes, we have.
Have we have any input directly from the Department of Health? Mike, do you know?
Mr. Chairman, not beyond what they indicate in the fiscal impact statement, but I can certainly follow up as we go through the budget process.
Well, do we need to stick calls on this?
Mr. Chair,
Senator Evans.
I guess if the Department of Health was going to absorb it with existing employees and really make information available, it shouldn't,
Shouldn't need a call.
yeah, if we're not suggesting that they had an employee.
Senator Evans should.
But if they were going to absorb it, they put together the fiscal impact statement. Wouldn't they indicate it as zero? If they were able to absorb it? I like,
That's what I don't know. I mean, that's the part that doesn't quite add up, and maybe we'll but if we send this to the full committee, I'd suggest we consider sticking a clause on it at some point if we don't get more information from the Department of Health.
Well, would you rather do that today, Mr. Chair, or a
Well,
motion?
we don't have to do that today, I don't think, but certainly as in the budget process.
Okay. Well, then, if a motion is in order, then I would move that we report this, recommend reporting to the full committee.
And I'll second that.
Okay, all in favor, say aye.
Aye.
Opposed, no. Okay, the bill is recommended for reporting. 325 is your other bill.
All right, thank you, Mr. Chairman. So for 325 here, the fiscal impact statement stated that the estimated price would be indeterminate. This is because it's difficult to estimate the number of birth certificates that would be requested with at least one adoptive parent that is an active duty or retired member of the military or military services. However, if there is a significant increase of requests that do need to be expedited, there may need to be additional roles from the agency. That said, so we worked this out, number one, with, so Delegate Coiner brought this bill to my attention. This was a constituent service issue that came directly from someone in her district. And in kind of having a back and forth on this, number one, we don't expect there to be a giant influx in terms of military members who are requesting the expedition of these records. Number two, those records, to simply expedite them, that's really falling more on the clerks of the court and at the local level as opposed to the state agency. And so the indeterminate part on this is just basically going to be based on, hey, how many people are really using it? And simply put, if we get to that problem, I would consider it a very good problem if a lot of military families are adopting a lot of kids.
Okay, does anybody have any questions for Senator Rome?
Yeah, thank you, Mr. Chair. I'm trying to understand what the need is here. This says when you need a new certificate of birth for someone being adopted, if there's a military parent on active duty, what are we doing for these folks? I'm trying to understand the need. Are they treated differently than other adoptions?
Yes. So, Mr. Chairman, I would tell the senator that The issue that happens here with military compared to any other one is that when you're trying to get your adopted child to be covered by TRICARE or basically covered under military healthcare system, that you're having a problem in terms of if that vital record is not being sent over in an expedited fashion, you can have kids or teenagers, whoever, go weeks, if not months, uninsured because of that. And so the point here is that you don't want to leave them uninsured at all. But if you're able to expedite this and get this done in 5 days, for example, you're significantly reducing the risk that something could happen and that you have, an uninsurance claim for, an infant or, or child.
Mr. Chairman, just for follow up, I guess the part I'm having a hard time understanding is this a problem for non-military parents as well?
So, Mr. Chairman, I would tell the senator that no, it's not the same level of problem because you might have, whether you're dealing with private insurance or you're able to negotiate that a lot sooner or a lot earlier. You might even have TANF cover or other like Medicaid coverage, whatever else it's going to be. But this is a very specific military and veteran problem for those who have TRICARE and other health insurance provided by military.
So, Mr. Chair, just to let my final question, just to make sure I understand this right, an adoptive parent who's not in the military, it's because of the military insurance program being more demanding of having the certificate right away?
Yes, Mr. Chairman.
Okay, but and as far as we know, civilian insurance programs don't require that same documentation as quickly, or Medicaid.
Yeah, Mr. Chairman, I would tell the senator that that is my understanding of it. And long story short on this is that by making sure you have the expedited one in military cases, you're cutting through that federal bureaucracy a lot quicker to make sure that you're getting that child insured.
Mr. Chairman?
Thank you.
Senator Favola.
Maybe this is a question for Mr. Tweedy, but reading the fiscal statement, it just says that it's hard to estimate if there would be an appreciable increase in the number of certificates of birth to be expedited. And then, of course, the next sentence says, of course, it might be nice to get, a position of $83,463. I think I would be willing to see first what the increase was before I actually allocated an amount. That would be my. What would you advise?
Yeah, Mr. Chairman, so I've actually spoken to the Office of Federal Records about this. So the substitute that came out of the other committee actually kind of dealt with their major issue, which was that they were supposed to turn this around like within 2 days. So now it allows them to expedite it. So they think it just, for that means that they'll just prioritize that when they're notified by the court that one of the parents is in the military, they'll just prioritize that birth certificate. There's just under 2,000 of these per year that are related to adoptions. So they really only anticipate a small number of those related to this. So at this point, they don't anticipate a major impact. And just to note that Vital Records is funded from their fees. So that we're talking about non-general fund resources here, not the general fund.
Mr. Chair, I would think we could report this without the clause.
Second.
That would be my motion.
Second.
Okay, is there further discussion? All in favor, say aye.
Can I just,
Senator Obenshain's got a question.
I mean, I have no problem with the policy. Why wouldn't everybody ask for an expedited birth certificate? I mean, everybody, I'm sorry.
I think that was his point.
Okay.
Yeah, that's that, yeah.
So, Mr. Chairman, I would tell the senator in this case that this is a very specific, TRICARE issue. And so
No, I mean, everybody who's eligible.
Oh, well, I mean, if you're eligible, yeah, go for it. But, Mr. Chairman, it's just, to me, what basically ends up happening here is, let's say you're at the clerk's office and you have the stack of these things that where you've just been given them from the judge has just sent them over, and then you're like, hey, by the way, the third one down, we've got a military one here, prioritize that, let's get that out the door. It's just which ones you're gonna take care of first at that point.
But to put a finer point on it, I mean, if Vital Records thinks that it's going to be sparingly used and probably won't require or may not require the $82,000, My question is, why do they think it would be sparingly used? Would seem to me, particularly if they knew that this is a military family, every single time they would recommend using it. So I don't know why.
So, Mr. Chairman, I'll tell the senator that it's based on the idea of how many military families and veteran families are actually going through an adoption process in a year, right? And so that number is significantly lower than the overall number of adoptions. You're dealing with a fraction at that point, and so you might only have a handful. But like I said at the beginning, Mr. Chair, on this, it would be a great problem if we had a whole lot of military families who were saying, hey, let's bring kids out of foster care. Let's bring kids, into kind, loving homes. Great problem to have.
Yeah, Mr. Chair, I just wanted to point out, unless I'm mistaken, these families with adopted children are going to get a birth certificate anyway. So what we're just doing is just prioritizing the 5-day period to make sure they get insurance. So I don't even know why there'd be much of a cost, just because the workflow might change to prioritize them. But they'd have to give them someone would have to do whatever is done to give them a certificate eventually anyway. That was just my comment.
Okay, we had a motion to support the bill, recommend the bill for reporting. All in favor, say aye.
Aye.
Any opposed? Okay, the bill is recommended for reporting. Thanks.
Thank you, Mr. Chair.
Okay, next we're going to hear from Nelson Smith about the Department of Behavioral Health's budget proposal.
Budget proposal. Okay.
Commissioner Smith, welcome.
Morning, Mr. Chair, members of the committee. Thanks for having me here this morning.
Thanks for being here.
Yes, bright and early. Well, as you know, this is one of the governor's biggest initiatives, transformation of the behavioral health care system. As you know, our 988 crisis hotline is one of the biggest keystones to that whole plan, Right Help Right Now. Right now, Virginia is averaging about 8,000 calls per month to our 988 crisis line, and about 80+% of those are being solved on the phone. This is a tremendous effort by our teams to build out the Virginia Crisis Connect system to ensure Virginians have someone to talk to, someone to respond, and somewhere to go. As you know, the someone to respond piece of the ones that we cannot resolve on the phone, we have what's called mobile crisis teams that can respond to a Virginian clinicians no matter where they are in the Commonwealth. And we're able to resolve about 70% of those in the field. And then it moves on to somewhere to go. As you know, we're building out our crisis receiving centers and stabilization units across the Commonwealth. Right now, we have about 159 crisis receiving center chairs and 114 crisis stabilization beds in development, and there's plenty more of those to come. The governor's budget builds on the $58 million that the General Assembly provided last session to accelerate this area of Right Help Right Now. We're also expanding alternative transportation and custody to relieve law enforcement. As you all know, there are many of them that sit for hours and days. We're also building on the co-responder model, where we have trained clinicians responding with law enforcement in order to de-escalate the situation. And also the budget includes funds for first responders and hospital personnel to get trained in crisis intervention training so that individuals that are in crisis are met with de-escalation, people who are trained to meet with them. One of the biggest proposals, sorry, I should be flipping slides here. There you go. That would have been nice to see, I imagine. All right, moving on. One of the biggest proposals and exciting is the governor's introduced budget with the target of eliminating the Priority 1 wait list. Over 3,400 Virginians are waiting for a waiver slot. That means they need care within 1 year. It's going to take a well-coordinated effort to make sure that these slots and the needed services are going to be applied appropriately and individuals get those care that they need. We're way ahead of the curve. As you might remember, a couple years ago, We had some issues, but we streamlined our process, and we're going to be able to address, or we will be able to allocate those slots timely.
Just because we allocate the slots doesn't mean we have the people to do the work. So the workforce development is critical. This
Absolutely, Mr. Chairman. We have
joined with this.
Right, absolutely. And the rates that were increased within those slots were very helpful. We understand that the slots by themselves are not the answer, but we were talking about it this morning. Without the slots, there's no business for people to move into. So we expect the expansion of the workforce as well.
Mr. Chairman. Commissioner, you got about $4.7 million put in for alternative transportation. This was a huge issue for our sheriffs. Is that enough money? Does that, and how many jurisdictions does that cover? And how many, based on the rate of commitments, does that match the rate of commitments and the amount of, is that enough?
Yeah, Mr. Chairman, Senator Reeves, thank you. So that's in addition to our current funding. So what we're looking at doing right now, I'm piloting a program. Now, when we inherited a lot of these things that we did 2 years ago, one of the things, alternative transportation, was not working. As a matter of fact, the utilization of it is less than 10%. It had a target in the contract of 50%. So what we did was we went back to the company and asked them to dig down and make sure that they're hitting these numbers. And so what we're doing is piloting a program currently with no barriers for transportation. Currently, they're not equipped or weren't equipped to take individuals in crisis. So now what we're doing is with this money, we would expand that pilot, which we know is successful, to transport individuals no matter what, because law enforcement is transporting them anyway, right? So meaning like it could be someone due to a mental health crisis, they're very acute, violent, so therefore they're not going to be transported by alternative transportation. This additional money will help us fund these programs throughout the Commonwealth.
So, Mr. Chairman, follow-up. Just a quick follow-up. So deputies and law enforcement, LEOs, are still going to have to take those that are committed, maybe that are violent and disruptive. Is that correct? Or are the new companies or the pilot program, are they DCJS certified to handle legally? They can transport prisoners?
Yes, Senator, by code too. Also with the alternative transportation, they're going to be the same certifications, CIT, everything that is required to transport these individuals. So the idea is to get law enforcement out of this business, but yeah.
Thank you.
Thank you, Mr. Chair. I just wanted to point out that I have put in a budget amendment for roughly $220 million to cover the costs of the services that would be provided to help with going back to the DD waiver slots to build the professional capacity to serve the community members.
All right. Any other questions? All right. So we have a process down to make sure those waivers get out, and we're confident we can do that. Again, a waiver has a litany, a list of services that are available. Not all individuals need every single one of those services. They access them as they need, which is a wonderful thing about the waiver. Also, the budget adds 8 new positions to assist in meeting the terms of the DOJ settlement agreement and fund peer-to-peer mentoring and employment programs through a contract with the Arc of Virginia. And we can do questions as we move along, that's fine. As you know, our youth have a big crisis here in the Commonwealth. And so there's a lot of activity that's happening in behavioral health services for our youth. We're launching new school-based services to support school staff so they can focus on education and reverse the pandemic regression, which dropped Virginia to 48th in the nation for mental health services for youth. Last year, the General Assembly funded efforts for permanent supportive housing, school-based mental health services, and a program to integrate children's primary care and mental health services through the Virginia Mental Health Access Program, or VMAP, as it's better known. The budget increases funding to meet the federal requirements for Part C early intervention programs, and increase the ability of community service boards to provide child and adolescent services throughout Virginia. We'd also start a new database that would simplify the way that mental health services are identified and accessed by both families and referring entities like schools. Also, there's been a tremendous success in the new Recovery High School in Chesterfield. The budget would sustain the funding as the program was started with federal funds. DBHDS is working hard to ensure Virginians can access quality services in their communities through STEP Virginia and other programs like permanent supportive housing. The budget funds new initiatives to improve behavioral health outcomes for Virginians. This includes evidence-based, peer-operated programs that can deliver high impact. And there's a program that I recently visited that offered classes throughout the day and even allowed law enforcement to drop people off as long as they weren't in crisis. And the program resulted in high levels of diversion, no barriers to entry. We receive funding to help prevent recurrent problem gambling that can lead to significant impairment, and these funds provide authority for us to spend those funds. The budget funds training for pre-admission screening to help update and improve modules in order to meet ADA requirements. And finally, the budget would allow 2 positions in DBHDS to manage the opioid abatement funds that come to the department. All right, our state facilities. As you know, it was a couple years ago, beds were closed due to the staffing crisis. Proud to say that we've opened up all the beds. As we know, that's not necessarily the answer, but staffing has improved. But all the beds are immediately filled.
All the beds, including all 48 at CCCA?
I would say all the beds that were taken offline 3 years ago.
So how many at CCCA?
We're currently operating, I believe, at 24. We're rebuilding as we speak. But I'm confident we'll keep moving until we get all those open as well. But that, again, that's not necessarily going to solve the issue.
No.
As you know, many people are still waiting on to get transported and get care that they need. At any rate, our hospitals are operating at or above 100%, as you saw in the JLARC report. It's not only because of TDO admissions, but also forensic admissions are dramatically increasing. Forensic admissions are people from jail who, for example, needed their competency restored in order to stand trial. We have 3 hospitals that are currently over 70% forensic. Eastern State, for example, is over 90% forensic. Virginia laws compel the state hospitals to take both TDO admissions and forensic admissions. As you saw in the JLARC report, adding expensive restrictive state hospital beds is not the answer. The new crisis services we discussed earlier to divert people and to give them the care in their communities is going to make a tremendous impact. The budget helps shore up critical but lower paid state hospital positions like food service and housekeeping, who can't, as you know, we can't run a hospital without them, and we're running 40+% vacancies in those areas. And also clinical staff like psychologists, social workers, lab techs, and pharmacy staff. The Workforce Development Program is a grow-your-own program to help workforce become certified. The budget also provides funds for Eastern State to move reimbursement staff out of a temporary trailer and to complete the new kitchen space. There are funds in support of Senate Bill 403 to create a new professional position to expand the workforce pipeline in behavioral health. And finally, the Boost 200 program in collaboration with the Virginia Healthcare Foundation helps people seeking advanced degrees in social work or counseling. And then this slide shows language only, zero-sum items, just like to highlight. Specifically want to mention language to combine the funds for alternative transportation and alternative custody. This provides flexibility to direct dollars to the greatest pain points for law enforcement and our system partners and ensures compatibility to support continuous care to the population. Also, the flexibility for inpatient admissions alternatives would allow DBHDS to move $5 million each year to divert state hospital admissions from jails to more appropriate settings. This would help us address the skyrocketing forensic census in the state hospitals we talked about in the last slide. Another item is to use the $1.5 million in earmark funds for people at risk of discharge from private inpatient settings into state facilities. Some of these people may not need continued hospitalization but lack community-based transition services, which makes them likely to be admitted to a state hospital. Mr. Chairman, this concludes my remarks today. Happy to take any more questions.
Thank you so much, Commissioner.
All right. Thank you.
Mr. Chair, I misstated. It was 20 million, not 200 million, so please accept my correction.
A little bit
Yeah,
different.
a little bit different,
Little bit
but
different.
just want to make sure that I said it out loud.
Okay. Now we're going to get a staff overview of the Health and Human Resources budget, resources contained in both the caboose bill and the regular, and the big bill.
Thank you, Mr. Chairman. So you've already seen this at the full committee. The difference here is I'll go in a little bit more detail and give you my thoughts about some of the things that the subcommittee will have to look at. So if you turn to slide 2, you can see for the caboose bill, Senate Bill 29, it's actually a net reduction of $85 million. This is really tied to Medicaid and the children's health insurance programs. Sort of the way that the story works is that this is the tail end of all the enhanced federal match. There's also some managed care rate settings where managed care rates were a little bit lower than expected in Medicaid, and that translates into the savings. Of course, when you get to the biennial budget, you see the significant increase in Medicaid, which is tied to the fact that the state has to pay the full share again. So I won't go into great detail about some of these things. I'll talk about at the end a little bit about the Children's Services Act. That sort of basically had been depressed a little bit during the pandemic, but now we're seeing growth in that program again. And you see that across the biennial budget. Just to note, the healthcare fund, additional money is needed there for the subcommittee's information. The healthcare fund is used as Medicaid state match. It's where tobacco taxes are deposited. It's where Medicaid recoveries are deposited, and pharmacy rebates, as well as a portion of the master settlement agreement with tobacco taxes. They were dedicated a long time ago to Medicaid, and as the revenues for that fund change, we have to make sure that the state match for Medicaid is fully supported. There is a reduction of $10 million. If you remember in Chapter 1, the September budget, $30 million was added to permanent supportive housing. I think from the department's perspective is that it's going to be hard to get all that out the door, so they took some of that as savings. But the $30 million is in the base budget going forward in the biennial budget to support that initiative. There's a few smaller items in social services, which we'll actually talk to because they cross over into the biennial budget, and a few language changes. The only other one I would note here is, as I think you've heard before, certainly there has been some mismanagement, financial mismanagement within the Office of Emergency Medical Services at BDH, and sort of understanding sort of the depth of that. That's what's going on. There's $12.5 million that gets transferred from this. This was a Great Recession. It goes all the way back to the Great Recession thing to get money to the general fund. So what they're proposing is to suspend that transfer in fiscal year 24, and you'll see in the biennial budget in fiscal year 25 to provide additional resources so that the office can continue to meet its commitments. So just moving to for Senate Bill 30, the biennial budget. So this just kind of summarizes, I'll talk through some of them as we go through it, but you can see the total $1.7 billion. Certainly this was the largest increase in the proposed budget. $1.2 billion is to fully fund the Medicaid program. So that's the normal increase in the forecast of utilization and inflation, as well as to backfill in the healthcare fund. So a large chunk of about $500 million is actually tied. One of the issues that happened during the pandemic was that, which we typically have never received before, is because healthcare utilization dropped down, and our Medicaid program basically pays managed care companies to provide that healthcare. Their payouts, basically their payment for claims declined. Fortunately, the state, we have protections in our contracts with them so that their profits aren't too great, as well as they have to meet a medical loss ratio of expending 85% of their funds and actual healthcare claims. So those triggers actually brought money, significant amounts of money each year back to the state. And so unfortunately, by the time it lasted for several years, it kind of got built into the budget. And now we have to replace that lost revenue because now things are sort of returning back to normal. Let's see. So starting off on slide 4, you can see, so this is Department of Medical Assistance Services, the Medicaid agency. So again, the primary costs here are basically the forecast, which we do every November. We talk, if you remember, I talked to you all about that back in the fall at the annual meeting. I've already kind of just talked about the healthcare fund. You can see, you add those two numbers together, the 714 and the 508, that gets you to the 1.2 billion to fully fund Medicaid for the biennium. As the commissioner had just spoke this morning about the developmental disability waiver slots, the 3,440, you can see that cost is 150 million over the biennium. So my understanding is that estimate was sort of the number to sort of like to end the waiting list as of November 1st of 2023. The waiting list, the numbers change over time, but it grows by at least by somewhere probably in the neighborhood of 500 per year, just depends on year to year. So of course, that's something you have to factor in, that you have to keep up with the normal attrition of the program and then add more in order to actually reduce the waiting list. And I think part of that discussion was also referenced the idea that the issue with, of course, waiver slots and the balance that you have to find is, I think the General Assembly, of course, has wanted to eliminate that wait list for years. So not only is it just a funding issue, but it's also the fact, too, that you need providers to provide those services. So that's kind of the balance that, if you add too many at one time, then people don't get services. They're probably going to call you all and complain about why they don't have services. So it's figuring out increasing, typically you would increase the provider rates as well to sort of like try to encourage more provider participation. So that's going to be, I think, one of the issues as the subcommittee goes forward and talks about that. The next two in here are just the children's health insurance programs, which are growing as well. As you know, the unwinding process for Medicaid will be supposed to be complete by about April, but it might take a few months after that to work through the backlog of the local departments of social services. But some of those people end up qualifying for the FAMOUS program, which is their main children's health insurance program, which is just at a higher income level. Just a few other things to note for DMAS. Replacement of the fiscal agency services system. So this is where they pay claims. Most of what Medicaid pays for now is through managed care, where we pay the managed care companies to take care of people, but there's still some services and still some things that are actually paid by DMAS directly. This is like a 20-year-old system for which I think the federal government, which is the Centers for Medicare and Medicaid Services, have said that they need to replace the system in order to continue to receive, I think, federal funds to support it. You can see the next one where it kind of says, where it references the modification of the DD waiver service limits. This is actually a bill that was passed last session. They're just kind of like reflecting the amount of money to fund it because we didn't fund it. The General Assembly, it was not included in Chapter 1 in September. So that's really more of a technical change. Then authorization and funding for managed care contract reprocurement. So this money, which is about 1.2 million, is for 3 positions and some other costs for that managed care, the reprocurement. I'll talk about a little bit that on the next slide. There's 3 positions for third-party liability. So this is where you have other types of, you have other insurance. Medicaid has to be the payer of last resort by law. So if you have some other type of payer for something, they try to make sure that the primary payer goes first and Medicaid just comes in and pays what it's supposed to in the end. You also see there is a saving strategy to restrict Medicaid coverage of weight loss drugs to basically people that have 40 BMI. So just to note on this is that typically in Medicaid, basically all FDA-approved drugs are usually covered. There are a few exceptions to that, and weight loss drugs are one of those exceptions. However, it kind of goes back to all the way back to 1999. There was actually an action to sort of cover this, but it really wasn't for weight loss. It was tied to some other drugs at the time that were dealing with anorexia. So it kind of put in there. So of course, when the first FDA-approved drugs for weight loss hit the market, Virginia's Medicaid program technically already covered them. Most states actually do not cover these drugs. I don't know if
Senator Boyce.
Can I just ask a quick question? That really is close to $9 million of savings? Is that what I'm saying?
Mr. Chairman, Senator Boyce, correct.
There's that many people who would be covered for this?
Well, Mr. Chairman,
Seems like a huge number.
So first of all, I think you need to know is that the drugs, as they currently are, because they're new, they are expensive. They tend to be probably in the neighborhood of $1,000 per month for the injections that you get. I think the issue is that thinking about, if you look at the data, the CDC would tell you that 42% of the U.S. population has obesity. So, even if it ends being that it is an effective way to deal with it, the one thing that as a state you'd still have to grapple with is how to pay for it, because a drug sort of that expensive across so many people could very easily translate into we're talking hundreds of millions of dollars potentially. So that's kind of the fiscal issue that's associated with it, whereas there's other policy issues,
I'm just going to say we had a pretty extensive briefing and study on this whole obesity issue and the Joint Commission on Healthcare, and we were pretty unanimous in our approach. The prescription drug issue related to obesity loss was supposed to be sort of the last approach in the pyramid. Nutrition changes, lifestyle changes, counseling, all those other things we were told were actually best practices that the medical profession was using. So the drug issue would be sort of the last strategy for helping an individual lose weight. Now, they may have to do a combination of those things and the drug strategy, but it was intended to be sort of the last resort. And the other thing is, which I think Mike pointed out, obesity is just such a condition that is an underlying factor in so many other very serious conditions, which in the long run, if we could avoid, diabetes or heart conditions or other things, we would be able to actually save money. So that was the logic behind all this.
Yeah, Mr. Chairman, Senator Favola, yes. It's a complex issue, and certainly, drugs can be a part of that. But from the state perspective, you have to focus on. I think a lot of people could get this, and in one degree, just for the subcommittee to understand, it's like you do pay for it, and to a certain degree, because remember, these drugs all started off as diabetic drugs.
Yes, they
are very effective as diabetic drugs as well. And of course, remember, doctors can prescribe any drug for off-label use, so they still have the ability to prescribe those drugs for that purpose. But just a weight loss drug itself, it simply restricts it.
And the increase in use means we have to employ some strategies, or else we are going to bust the budget on this. Hundreds of millions of dollars.
Mr. Chair, I just didn't have any understanding of the scope
Context.
and the cost of this. I was a little bit shocked by those numbers.
Yeah, and then just to kind of finish out, Mr. Chairman, for DMAS, the environmental commitments forecast, this is a state-only program where you pay for the cost of TDOs and stuff. So it's not a huge fund, but that changes. That's forecasted every year, and it's actually, the total number of TDOs has actually been going down some, which is certainly a good thing as well, and there's some savings there. And the last one is clarifying coverage of prevention services. Is just making sure that we align with federal law and we get a slightly enhanced federal match for prevention services for doing that. So I did just want to note this slide just to kind of give you an overview of Medicaid managed care procurement. Procurement, you probably heard me talk about it at the annual meeting in the fall. The subcommittee back last session talked about this as well. The reason why I kind of convey to it that it's so important is because it really becomes the single largest contract that the state enters into. So when it's awarded, if you think about the fact that we pay $15 billion a year right now for Medicaid managed care, $15 billion total funds. So there's a large portion of that's federal. But if you do like the proposed to have a 6-year term, that basically means you're locking into $90 billion. And of course, we adjust the rates every year to reflect increasing cost of healthcare services. So that's a very significant cost that that the state or contract that the state is entering into. So I think as the subcommittee has discussed in the past, trying to make sure we get that right is very important. So you can just see that this just kind of gives you the summary that basically last summer that the request came in, proposals were due in October. They plan to award them probably late winter or early spring, and then implement it by July 1st of 2024, which last year, that was one of the discussion points for the subcommittee, is that seemed like a very rapid timeline, and trying to get this right is certainly, I think, important for the Commonwealth. And then I just noted here, there are changes to the existing contracts, so they have a little bit of cost, and some of these things are what's funded on the other slide. So moving to behavioral health, like I said, I won't go into great detail since the commissioner already briefed you this morning on this one. But as you can sort of see, it's almost $90 million for these services. Funding additional crisis services, I think you're familiar with the crisis receiving centers. So this is funding some of those and crisis stabilization units. Another $35 million to build that out. There's $10 million for the psychiatric ERs. Carillion has one. I think Chesapeake Regional is developing one. Riverside has one that I think they did on their own. But that's another way to kind of treat people immediately in the ER with psychiatric conditions. $10 million to continue to build up mobile crisis units. I think you already talked about the alternative transportation and custody program, and I'll just comment too. I think Senator Reeves was questioning earlier was that that's kind of a program with a lot of hopes as to what it would do, but it's been a rockier road to implement for a variety of reasons. One I'll mention too is when it first started was, remember, at the end of the day, it's the magistrate that determines the provider. So I think early on, I think they were concerned about turning it over to the contractor, and they oftentimes felt more comfortable with just law enforcement doing it. And so that's just one of the many issues that you face, in trying to sort of change behavior to try to use some of these new tools for people. I think you already mentioned the co-responder programs, continuing to implement that in accordance with the code section. The peer wellness stay programs, which are really basically peer-led sort of recovery programs, $6.7 million for that. Increasing training for first responders and hospital staff. So this is CIT training, but it's basically tied. It's more that we had more federal funding that's kind of gone away, and so it kind of requires general fund to continue that training. I note in here it's actually a DMAS, a Medicaid thing, the 20 psychiatric residency slots. So we do have a program where we fund residency slots through Medicaid. And that continues to fund some of those, and expanding funding for adolescent substance use services. So again, that's expanding other opportunities for people to recover from substance use disorder issues. Then I'll note for DMAS 2, there's completing the redesign of the Medicaid behavioral health services. Medicaid is one of the largest payer of behavioral health services, and this is a process that's several years in the making to basically redesign those services to be more evidence-based and to try to see if they can't become more effective than what they were. So, and I know that we're losing a couple members, and certainly, right. And certainly if there's any follow-up that y'all have with me, just let me know. As moving on to the behavioral health facilities, as the commissioner talked about, so there's some salary changes. It's about $39 million total for some of the clinical roles in the state hospitals, as well as the food and environmental services staff, to kind of help reduce with their turnover vacancy rates within that system. There's funding the temporary kitchen at Eastern State. There's a capital project to replace not just the kitchen, but some other stuff at Eastern State Hospital. But before that project has actually come to fruition, because it's still actually, I think, in the planning and design phase, they had sort of a sewer problem that required them to vacate it and use a temporary kitchen. And this is funding to continue that operation. So that's a couple of workforce things in the facilities to expand clinical training sites, especially with partnering with other hospitals and the teaching hospitals. Grow your own workforce program, which is trying to more pathways and opportunities for like nurses and stuff to like increase their certifications within the state hospitals. And then some pre-admission screening to become ADA compliant. You'll see a couple savings items listed here. The one for the Medicaid appropriation for state facilities is just that there is an appropriation in Medicaid to fund the state facility cost. It tends to be more for like the training centers, which we really only have Southeastern now, and then Hiram Davis in Petersburg is also considered a training center. They're the primary entities that receive Medicaid. And then lastly, there was the maintenance of Central Virginia Training Center. So they're taking $1 million out of that budget for that, under the idea that they're going to sell it. I think that's certainly one of the big questions, is that if you know much about it, it's a large campus with many old buildings, and it's not going to be an easy path to actually.
Do you know if there's
I
an
think.
offer on that property? Anybody's, I know there's a master plan for it, but I don't know if there's actually been an offer for it.
So, Mr. Chairman, so I don't think there's an offer. I can certainly double check. I mean, it's kind of still in the phase where they're preparing it to actually turn it over to General Services to surplus it. But if you recall, in this last budget, before Senator Newman went out the door, he did put into place sort of like a grant program within, it's under, I think, economic development, that if a developer were to make an offer and purchase it, that they would provide this incentive grant to help them deal with.
It is a significant piece of property, and there are a lot of old buildings there. Most of them are empty, but law enforcement still does some training in the area. Now, is there any funding left to maintain the property at all until it gets sold?
Yeah, Mr. Chairman. So yes, I mean, normally what they basically do is, and they still have other properties as well. They like to get them to the stage where all they do is provide like some basic minimal security, because that is one of the big problems that they have on these campuses, is sort of like a lot of people like to come on them and do whatever it is they want to do, ghost tours or, that sort of stuff. And so trying to keep people from coming in there and getting hurt and stuff is certainly one of their priorities. And then, of course, mowing the grass and that sort of stuff. Central Virginia, they're spending more money because, if you remember, it's either 4 or 5 buildings that were renovated probably maybe 15 years ago or something. And so they were trying to so their goal was to kind of keep them in a place where they could still be useful if someone wanted to make an offer on their property. So you don't want them to kind of degrade into.
Were the improvements in those buildings related to the bonds we fused?
Yes, Mr. Chairman, yes. Which they're now fully defeased, so the property could be sold at this point if you could find a buyer. And then just to conclude with the Department of Behavioral Health, Part C Early Intervention Services, these are not the non-Medicaid side of it. Medicaid pays for Part C as well for kids that need these. So this is a normal thing that has to be funded in order to match the normal growth. There's some other initiatives within the department for looking at the mental health workforce. You mentioned Boost 200, which is one of those. Just to note what else. So a few things that, there are a few savings items. The local inpatient purchase of service, which is about $2.4 million in savings. That's really just that the spending that for that initiative is has been less than they actually had anticipated for some time. So they're just reducing that appropriation. That's where they purchase private bed space to supplement the state hospitals. You can see there's one for the Crisis Call Center fund balances. Crisis Call Center receives the fee on your cell phone or whatever that you pay an actual 988 fee. So that helps support the Crisis Call Center. So there was general funds to kind of get that started. And essentially what this does is basically help to, that was to kind of bridge them over. So they've been slowly ratcheting down the general funds that they had for it. Then also for children's inpatient services, that's another appropriation that was provided to kind of supplement the state hospital space. And again, that contract has been a little bit below what they were expected. Appalachian Telemental Health, this doesn't really impact the program. When that pass-through started a number of years ago, they didn't spend it in the first year, and this $1.1 million has been carried over every year since then. So it just kind of takes away that initial money that they never really needed. And there's a small elimination of a technology contract for DBHDS.
Mr. Chairman.
Senator Evan.
On slide 8, the second line about funding initiatives to expand the mental health workforce, I know that's really important. I was just wondering, is that enough? Do we know what they're going to do with that money? That's the total, and how it works?
Mr. Chair, Mr. Eben, there's actually several components to that funding. I mean, that's just one piece. If you look at the Boost 200 below that, some of the stuff on the other sides. There's a variety of things that they're doing for healthcare workforce. But I can certainly get you the details on what the several components of that. There's a position in there and a few other items, but I can
Okay.
share that with you.
Thank you.
Slide 9, Department of Social Services. So the first item here, which is the largest item, $15.9 million, is the Relative Maintenance Payment Program and funding supports for kinship and alternative living arrangements. So this is going to be really tied up with Senator Favola's bill that's in the Finance and Appropriations Committee now to figure out really how much that cost. But this funding technically sort of supports that effort. The Relative Maintenance Payment Program started during the pandemic with TANF funds, and then was shifted to general funds. But that's sort of all caught up with that bill. I think last week the commissioner, DSS, had talked about costs for the income verification for public benefit. So this is basically a contract they have with Equifax to do income verification, and that contract cost is much higher than it used to be. The TANF block grant shortfall, which I actually, in 2 slides, I'll kind of give you a high-level summary of it. This is just converting those pass-through grants to basically general funds. So they're not really cutting them. The funding for the summer EBT program for children. This is something that was in the pandemic that Congress made permanent this past fall. Essentially what it does is it provides an additional $40 a month during the summer months to support kids. It's like a supplement to the SNAP program. There's also the $4 million for the fatherhood programs. I think the commissioner last week kind of talked about. And then the child welfare forecast. So this is where the forecast, the feds actually support foster care and adoption assistance payments in certain situations. And so there's a forecast every year that we do for that. And so you can see the $3.2 million in costs there. The funding for the SNAP overissuance settlement agreement. This is where the state had accidentally overpaid the benefits, and so the $6 million was sort of like negotiated down and over a 3-year period. So these are sort of the payments to sort of cover that. And typically the way the feds do with this is you can negotiate it down if you're willing to invest more in the program. So that's a part of what they agreed to do to reduce the $6 million payment that they had to give back. Then there was just a transfer from housing there was a bill, I can't remember, in the last couple of years where the funding was put under DH, Housing Community Development, but this just moves it to DSS, where they actually sort of administer it. And then there's an increase in funding for the SNAP EBT program contract. So this is sort of the contract that administers the program. On the next slide for social services, there's support for the Judge Sweat Learning Center. So this is a pass-through grant that the General Assembly actually funded in recent years, so this adds an additional $500,000 per year. There's this funding for an advanced contact to Medicaid recipients at renewal. So the idea here is that they would text individuals to see if they don't want to continue their Medicaid. Then the APS hotline capacity. So Adult Protective Services is basically, the policy over it is set by Department of Aging and Rehabilitative Services, but DSS actually continues to operate the hotline for Adult Protective Services, and this is just some additional funding to support that. There's also some funding to convert a couple of part-time SNAP evaluation positions over to full-time with their associated cost, and a little bit of funding to do background checks for local DSS employees and contractors to make sure that they all have a background check. There's also savings of $5 million per year this is Family First Prevention Services funding. The rollout of Family First certainly has been much slower in getting prevention services built up, so they take that savings out in each year. You see the fund TANF benefits and the Virginia Initiative for Education and Work. So that's another forecast. So TANF is really just non-general funds. Where the general funds come into play is TANF. We have an unemployed parent program, which is basically, it's a state-funded program so that we don't have to meet the federal work participation requirements. And that's the only place where there's general fund within TANF that changes from year to year. And then, of course, they have the savings from their rent decrease from their move out to Innsbruck. So, and just talking about on the next slide, the TANF block grant summary. So as the subcommittee goes forward and does its work, we'll actually look at the entire TANF spreadsheet and everything that it spends its money on. but you can see the mandated services. This is part of how the issue with the block grant kind of gets solved, because now that the pandemic is over, the work requirements for TANF recipients is back in place, and you actually see a pretty dramatic drop in TANF benefit payments, which is only a small component of this grant. The other major expenditure mandated service is actually local department cost. And then the discretionary grants, that third line, is what typically the General Assembly likes to kind of deal with as people request money. Those are the discretionary grants. And you can see as those phase down from 61 to 44 million, that's where they're replacing them with TANF and using general funds to replace the TANF funds. So you can see the total TANF budget is to go from 194 million to 157 million. And if you see right down below, when you get to fiscal year 26, the grant amount is 157.8 million per year. The TANF grant hasn't changed since it was created in the 1990s. So that's pretty much what we get from TANF, the 157.8 million. So you can see by the 26, it sort of kind of comes into balance. And then the bottom is just showing you the prior year balances and how it changes from year to year, how you get to sort of in balance by fiscal year 26. Then the last major agency is the Department of Health. The top line, again, just talked about TANF. There are a few items within the Department of Health that were funded from TANF. They're all getting converted to general fund so that they don't have to deal with TANF at VDH going forward. There's expanding the behavioral health loan repayment program, which is about 10 million. And then the next one is 8 million for the nursing education acceleration program. So these are actually newer programs. One's providing loan repayment for behavioral health professionals, and the other one is basically helping to support nurses sort of like, get higher credentials and stuff within nursing. Then you can see 6.2 million for the matching funds for the drinking water infrastructure. So the Bipartisan Infrastructure Act that the feds passed in the last couple of years had a lot of additional money for drinking water projects, and so this is the state match for that. The federal share is probably in the tune of 90 to 100 million each year. Then there's 3.6 million to fund agency financial oversight. As already mentioned before, the department has a lot of issues in their Office of EMS, and I think probably even maybe some other places. And this is additional funds to support those efforts to improve the agency's oversight. There's $2.5 million the first year for Hampton Roads proton beam therapy. There's already an existing appropriation for this, so this is an additional one time in the first year for that pass through to them. There's 1.9 million over the biennium to expand nursing scholarships and loan repayment programs. So this is more of just a nursing loan repayment program, and it sort of doubles the funding for that. There's 1.2 million to establish an Office of Grants Administration, which is probably something that should have been done a long time ago for VDH. They probably have more federal grants than any state agency. They're not all, many of them are small, but still managing all those grants takes a lot of effort. And then just to note, I added up a few other, there's the 2.4 million at the bottom includes matching funds for home visiting services, which is also a federal program. There's the ALS Association that increases the amount for them, and the Special Olympics pass through. And there's 2 staff to support the healthcare workforce incentive programs for the department. And the last slide, Mr. Chairman, just covers the other remaining HHR agencies. There's funding to add an additional position for the Secretary of Health and Human Resources to support all the work that they do. For the Children's Services Act, you can see $48.5 million per year. So again, the largest driver of the Children's Services Act funding, and there are other things embedded in here, is really private day special education. It's an issue that the General Assembly has focused on for many years. It's not an easy one to deal with, but essentially, it's actually CSA that pays for when a kid is moved from a public school to a private school for special education. It actually comes out of CSA's budget. The fundamental issue, I think, for you all is from an HHR perspective is those decisions on who moves to private day are made in IEP teams at the local level, and really there's very little control that the state has from this perspective. So, it's not to say that it's not, those kids don't need those services. It's really just the idea, but there are costs to paying for them outside of the public school. But again, there continue to be efforts, I think, on the public school side to try to make sure that you can, for those kids that could stay there and can be handled there, and that kids that would need a more intensive private day would move to private day. Then the kinship alternative living arrangements, again, is tied to the DSS funding for kind of like the foster care bill. There's a small kind of technical thing in aging and rehabilitative services that's related to the salaries for Centers for Independent Living. And then there's the Opioid Abatement Authority, which is actually an agency created under HHR, provides a base appropriation for the grant payments that the Opioid Abatement Authority pays out. So with that, Mr. Chairman, unless there are any questions, that concludes my presentation.